Good morning, everyone. Thank you for joining us for this week's virtual journal club. My name is JP Brito. I'm an endocrinologist and associate professor of medicine at Mayo Clinic, and I will be serving as a co-host of these wonderful journal clubs, along with Mark Urken. This morning, we are honored to have one of my colleagues at Mayo, Dr. Bezon Dy. He's going to present a lecture on persistent hypercalcemia after parathyroid surgery. Dr. Benzon Dy is a board-certified endocrine surgeon and associate professor of surgery in the Department of Surgery at Mayo Clinic. He's also the program director of the Comprehensive Endocrine Surgery Fellowship and the Thyroid and Parathyroid Surgery Division lead in the Division of Endocrinology and Metabolic Surgery at Mayo Clinic. Dr. D received his MD from Georgetown University School of Medicine and then completed his general surgery residency at the Mayo Clinic. He remained at the Mayo Clinic to complete a fellowship in endocrine surgery and went on to have 6 additional months of training at the Sloan Kettering Memorial in New York. Dr. D currently serves as a member of the faculty of the American College of Surgeons and is a member of the Robotic Research Committee for the American Association of Endocrine Surgeons. He was recently awarded Teacher of the Year in the Department of Surgery at Mayo Clinic and previously served as a member of the Career and Leadership Development Task Force of the American Association of Endocrine Surgeons. Now, I will turn it over to Dr. D. Thank you very much for being with us.
All right, thanks, JP, for that introduction. I'm really honored to be participating with the Thank Foundation for and presenting on persistent hypercalcemia after parathyroid surgery. What are the considerations? This is a difficult problem that everyone who performs parathyroid surgery will eventually encounter. And so I am going to share my experience and our approach here at Mayo Clinic, as well as what the current trends and literature shows are to be the most effective way to approach the persistent hypercalcemia. I have no disclosures. And so I just wanted to start this with a question so that we can frame our discussion. So 6 months after parathyroidectomy, a patient with preoperative calcium of 11 milligrams per deciliter returns with a calcium of 9.4 and a PTH of 87 with a reference range of 15 to 65. The most appropriate next step is to A, obtain additional localizing studies, B, reoperate with laryngeal nerve monitoring, C, check vitamin D level and annual calcium monitoring, D, PET choline imaging, or E, bisphosphonate therapy with lumbar X-ray imaging. So in this particular patient, what we would recommend would be to check vitamin D level and annual calcium monitoring. And I will review why we choose this. So for persistent hyperparathyroidism, cure is defined by normalization of calcium levels 6 months after surgery. So our previous patient's calcium was 11, went down to 9.4 at 6 months. So that patient is considered cured. However, when you check PTH in these patients postoperatively, in multiple studies that have been done, it shows that up to 40% of people will have persistent elevation in parathyroid hormone, even with normalization of calcium levels. And we don't always know why this is. We think many times you're unmasking secondary hyperparathyroidism. It could be due to bone remodeling that's happening or changes within the kidneys. So the established definitions for these are persistence is elevation in calcium within 6 months after surgery, whereas recurrence is normalization of calcium at 6 months and then elevation at any point in time after that. And interestingly, just as a side note, we had traditionally thought recurrence in these patients would be about 4% in their lifetime, but looking at population-based studies, which we'll be presenting in April at the AAES this year, shows that up to 15% when you follow these patients up to 50 years will have potential recurrence of hyperparathyroidism. So just something to keep in the back of your mind. In a high volume endocrine surgery center, success rates for surgery for primary hyperparathyroidism should range anywhere from 95 to 99%, depending on surgeon experience and the referral patterns at that center. At-risk groups for hyperparathyroidism include postmenopausal women, where this happens most commonly and compose about 75% of patients, and patients with a history of radiation exposure, including possibly radioactive iodine after thyroid cancer. Patients with genetic mutations such as MEN1 and MEN2A will have penetrance of up to 100% if they live long enough to develop hyperparathyroidism. And then patients with renal failure and chronic calcium leaks will develop secondary and potentially tertiary hyperparathyroidism. And then medications such as lithium use are known to promote multiglandular disease for resulting in primary hyperparathyroidism. What are the causes of persistent hypercalcemia? So failed surgery certainly is the most common. Missed adenomas in these patients will be the most common cause. So patients may have false positive imaging, such as a hot nodule that may mimic a parathyroid adenoma. Areas with retained technetium-99 on a sestamibi scan may give false positives as well. And so things such as lymph nodes can show up on some of these studies, and so can give a surgeon a false sense of security that they're going to find a parathyroid at a particular location, and then may result in needing a four-gland exploration, and then having aberrant locations for these glands can lead to failed surgery. Incomplete surgery is another common cause. So patients may have double or multiple adenomas, which is relatively rare, but we estimate somewhere between 5 to 10% of patients may have more than one adenoma. Missed multiglandular disease, so patients may have small but hypercellular glands, or not true adenomas, but just hyperactive glands that are enlarged, and removing one or two of these glands may not be sufficient in resulting in normal calcemia. And then incomplete resection of adenomas can happen as well. And so if they're bow tie or dumbbell shaped, you may think that you're resecting the entire gland, but you could be leaving potential adenoma behind. We try to avoid incomplete surgery by utilizing adjuncts such as intraoperative parathyroid hormone, where after resection, either 5 to 10 minutes after resection, we measure the parathyroid hormone, and it should come down to the normal or near normal level, and decrease by 50% of the pre-incision parathyroid hormone level. But this is not 100% accurate. It's very accurate, but there are a couple percent of people who will drop down to the normal or near normal range if the remnant is devascularized, for example, and then will have persistent disease within 6 months. Just to note, localization is not a requirement for cure in these patients. We had looked at this back in 2012, and patients who had negative imaging still are candidates for cure. But what we did find that is pertinent to this discussion is that people who did not show any sestamibi activity on subtraction imaging did have a lower cure rate, and this was due to missed multiglandular disease or multiple adenomas, so consistent with our previous slide. So when you have a patient who has persistence of disease, the next step is to revisit your diagnosis and to review your lab. So you want to make sure that you have the correct diagnosis and that this is indeed primary hyperparathyroidism. So many of these patients will often have surgery locally and then proceed to a tertiary center, for example, when they are not cured with their initial surgery. So wanting to make sure that you are secure in your diagnosis of hyperparathyroidism prior to proceeding is certainly very important. You want to consider repeating your labs, including calcium, parathyroid hormone levels, vitamin D levels, and phosphorus, checking creatinine levels, and then consider repeating your 24-hour urine calcium and creatinine to reinforce your diagnosis. You want to consider other diagnoses as well that can look like hyperparathyroidism, such as FHH, sarcoid, tuberculosis, and then looking at other lab values such as PTHRP, and then reviewing their medication list, because something as simple as hydrochlorothiazide can really make your mimic persistence of disease. And then when you're considering repeat surgery, because a redo neck operation has different risks and benefit profile, you want to really consider what is your indication for surgery. So the fifth consensus conference does have recommendations such as for asymptomatic patients, such as osteoporosis and renal symptoms, and then also looking at if patients are symptomatic and having things such as fatigue, forgetfulness, brain fog that have been described as side effects of hypercalcemia and hyperparathyroidism. So it's important to counsel patients that in persistent disease and when you're considering reoperation, that there are an increased risks of complications with a second operation. Hypoparathyroidism, depending on how many parathyroids were removed from the previous operation, is a very real and significant risk in these patients. I always tell patients that hypoparathyroidism is way worse than having hyperparathyroidism in the majority of cases, and is a very significant source of morbidity. And so it's important that they realize that this can be a potential cause. Even if they have the previous op reports say only one gland was removed, you really just don't know what a different surgeon has done in the neck before you when you're doing a reoperation. Recurrent laryngeal nerve injury in any reop situation is always higher than any de novo surgery. So in initial surgery, it's usually 1% or less. And in the literature, it has been documented to be up to 20% to have transient nerve injury and much higher than 1% of permanent nerve injury in the reoperative situation. Thyroid resection can be a possibility in a first or redo surgery as it's more likely to have aberrant locations such as an intrathyroidal parathyroid in these cases. And then four-gland exploration in the reop situation is much more difficult because of scar tissue and risk of injury within the neck. It is not always feasible to do a four-gland exploration in the reoperative situation. So localization will be key, and we'll talk more about that in the next few slides. So here's a case to highlight our approach to recurrent hyperparathyroidism. So this is a 50-year-old female attorney with worsening osteoporosis referred with persistent hyperparathyroidism 6 months following unsuccessful bilateral cervical exploration and partial left thyroidectomy by an experienced endocrine surgeon. Vocal cord exam is normal at 6 months. So important things to highlight with this is she has certainly an indication for surgery with osteoporosis that is continuing to have a decline in bone density. She's young at 50 years old, and she was operated on by an experienced endocrine surgeon. So knowing that someone who knows how to look for parathyroids, and does the surgery often, are all important points in her history. So first, we review the operative and pathology reports, and this is really a must in any cases where you're considering reoperation. So she had a normal left superior gland removed, and on the right side, 2 normal parathyroid glands were visualized and left in place. The left inferior parathyroid gland was not identified. So right now we should have 3 good parathyroid glands that are left, or 2 good ones and in theory 1 adenoma. The pathology did confirm normal cellularity in the 1 parathyroid that was removed. And then she did undergo the left thyroid lobectomy, and there were no abnormalities and no parathyroid tissue identified. So when we review her lab values at 6 months, we see that she has persistence of disease with a calcium of 11.2, and we know that 1 milligram per deciliter above reference range is another indication for surgery for this patient. She has a depressed phosphorus that helps support our diagnosis, and her PTH is elevated at 84 picograms per milliliter. Urine calcium is also elevated at 500 milligrams per 24 hours, which is another indication for surgery for her. So we repeated her sestamibi scan, which is something we do often here at Mayo, and we're very lucky that our subtraction imaging with technetium-99 and I-123 here is really quite excellent. And so this is an important point to really be familiar with the strengths and weaknesses of imaging within your institution, because some places and some institutions have very poor sestamibi imaging, and will prefer to use other localization studies. But we're very lucky here that many places that don't localize on outside imaging, we repeat the sestamibi here, and we're able to find abnormal parathyroid glands. So on the left is our technetium-99 sestamibi, which highlights thyroid and abnormal parathyroid glands. The I-123 shows our thyroid, and then we subtract the thyroid from the thyroid and parathyroid and left get with parathyroid alone. So on our anterior view, we see something on the left side. So this is interesting location because on our previous op report, we saw that a left superior parathyroid gland had previously been removed and was normal, and no left inferior gland was identified. The other interesting point is the thyroid had been removed on this side, but they were unable to identify where this gland is. So the next best step in management of this patient would be A, to obtain additional localizing studies, B, reoperate with laryngeal nerve monitoring, C, radio-guided parathyroid surgery, D, video-assisted parathyroid surgery, or E, continued observation. So for this patient, I would recommend obtaining additional localizing studies. So B certainly is an option to reoperate with this localization, but we want to remember that that another experienced surgeon had looked in that area and didn't find anything. And so that makes me a little bit suspect that it's not just going to be your typical superior parathyroid that's going to be in your tracheoesophageal groove, for example. Continued observation could be an option, but she is interested in surgery and has multiple indications to consider it. So I would recommend obtaining additional localizing studies. Looking at cross-sectional imaging for this patient, we are able to see that on the right side, this is your jugular vein and your carotid artery, which is present on the left side as well, but there's an additional mass that's present within the carotid sheath here. And so very suspicious and consistent with our previous imaging to be a parathyroid adenoma. When we do internal jugular vein sampling, we see that the left side is markedly higher than the right side, which also supports our diagnosis and our localization studies. So it is important in persistence of disease that multiple concordant studies are available to assist you with cervical exploration to make preoperative surgery successful. You don't always have the luxury of having multiple studies that are positive for parathyroidectomy, and so adjuncts such as selective venous sampling can be helpful to narrow down and hopefully decrease the amount of dissection that you're going to do intraoperatively. So in this case, we have both a sestamibi and cross-sectional imaging that is concordant, as well as as venous sampling that supports our diagnosis. So in this patient, because we suspected that it is in the carotid sheath, we did a lateral approach, going lateral to the strap muscle and medial to the sternocleidomastoid. And we were able to find a parathyroid adenoma just medial to her carotid artery. And then her parathyroid hormone intraoperatively came down nicely, and she was cured from this. Here's a second case to highlight additional imaging studies. This is a 52-year-old chemistry professor who I recently saw. He had 2 previous operations that were failed, including one at a famous Florida parathyroid clinic. And current calcium level is in the mid-11s as well, and parathyroid level 255. Had a left hemithyroidectomy as well, actually, and had either 1 or 2 glands resected, depending on how you read the operative reports. But it looks like 2 of the left parathyroids were resected. Internal jugular sampling for this patient showed equal levels on both sides, so in the 250 range on both the left and right IJ sampling, and pretty close to the patient's peripheral sampling level. So in spring of 2020, he came to see me and we did a sestamibi scan, and really don't see much here. We see a little faint shadow here, but on the washout, we don't see much. Up here are salivary glands, so this is not parathyroid tissue. In retrospect, there is a tiny shadow here in the chest that we recommended additional studies for this patient, but he was reluctant to come back. He was from upstate New York, and so the pandemic hit, and then he comes back to see us. So we do have multiple additional imaging studies available in 2021 these days. So we talked about selective venous sampling. SPECT-CT is an adjunct that we often use to our sestamibi, although in the past we've found that it only improved our study by about 3% for positive predictive value to a sestamibi alone, but does add significant cost. So we do use this selectively in patients that have a high suspicion of multiglandular disease or aberrant locations for this, or in redo operations. It also does add a significant radiation exposure for patients. 4D CT scan has been very popular the past decade, and we continue to use that in difficult cases. Some institutions choose 4D CT scanning as their imaging of choice, which is a very reasonable option as well. And then one thing I'll talk about towards the end of this is the rise of using C11 PET choline imaging, which will probably become the best imaging study for hyperparathyroidism in the future. And so in spring of 2021, he comes back, and so we decided to repeat his sestamibi scan because a year had passed, and so we restarted his evaluation. And that area in the chest has become more prominent here, and on our subtraction imaging, it is certainly more suspicious. So then, to complement this, we performed a 4D CT scan, and on his Cross-sectional imaging, we see an area here that is hyperenhancing with contrast from the takeoff of his innominate artery and just adjacent to his right carotid artery. We see about a 1 centimeter lesion here, and this all corresponds to the uptake of sestamibi. And so we take him for parathyroidectomy. We're able to access this area with an extension of his neck because it is just at the thoracic inlet. We're able to do this cervically, and we found a 1 centimeter parathyroid, and his intraoperative parathyroid level, hormone level, declined nicely at the time of his operation. One important consideration for this gentleman is because he's had 2 previous operations, so this is his 3rd one, is hypoparathyroidism, as I mentioned previously. So in reoperative situations, many times we treat the parathyroid adenoma like it's the patient's last parathyroid, especially if they've had bilateral exploration. And so in many of these cases, including this gentleman, will auto-transplant a portion of the adenoma into his chest wall. And now some experts will quibble about this a little bit because you are auto-transplanting diseased tissue with the potential to have recurrent disease occur within the chest. But we believe that this is worth doing to avoid hypoparathyroidism. One technique that we do is, most commonly, we will do transplantation into the chest wall within the adipose tissue of the chest wall. And this is a electron micrograph that shows parathyroid tissue that it has neovascularization within the adipose tissue. So we do know that this is very effective and up to 95% chance of uptake when implanted within adipose tissue, as opposed to putting it where we would traditionally implant this tissue, which is the muscle bed of the radial forearm, which in recurrent situations can be difficult to resect due to having to remove a significant amount of surrounding muscle with the parathyroid tissue. The advantages of using the chest wall are that in repeat sestamibes, which if this patient were to recur, we could, the chest wall will be included within that imaging field. And so if an adenoma shows up there, we would be able to see it on a repeat sestamibi scan. Second is, if the patient's parathyroid hormone level is detectable within 24 hours, for example, the morning after surgery, you could remove this auto-transplant at bedside and avoid the chance of having recurrence from the implanted adenoma. The other option that we have here at Mayo is to do ethanol ablation. And so you can titrate this. You can titrate the parathyroid level by ablating 0.1 milliliters of ethanol into the implant site and then rechecking the parathyroid hormone level within 6 hours. And once it reaches normal, you can stop your ethanol ablation. This does not have the greatest long-term success, and recurrence is high in these patients, but it is an option to help avoid hypoparathyroidism. And then I just wanted to mention C11 choline PET imaging for detection of parathyroid adenomas. So this is something we've been looking at for about the last 5 years here at Mayo, and many other centers such as UCSF have been doing a lot of research in this area. It will likely be considered to be the best study down the road because it is highly specific for structural disease that is present and can be surgically removed. Initially, this was studied in prostate cancer patients because this is the study of choice to look for recurrent prostate cancer. And when we retrospectively looked at about 3,000 patients, when we looked at their calcium levels, we found 13 of them that fit a diagnosis of hyperparathyroidism. And reviewing those image studies, because they are from there are full body imaging scans, 13 out of 13 adenomas were found in these patients. It is currently awaiting FDA approval. It has a very high cost, can range anywhere from 7 to 15,000, and insurance companies are increasingly paying for these, but not all. And so many patients may have may get stuck with the bill for this, and so have to make sure to review that with both the patients and get pre-approval for it. Currently, we are reserving it for non-localizing patients and difficult reoperative cases. It is not widely available in many hospitals because of the volatility of transporting and creating C11 choline, but we do have it available here at Mayo. So just to highlight what a C11 looks like, this is a 75-year-old woman with osteoporosis with a calcium of 11.1, PTH is 100, T-score significantly low with negative 3.3 in her femur, and so high risk of hip fracture and femur fracture in this woman, which is significant because many of these patients will lose independence once they develop a hip fracture. Urinary calcium 375 over 24 hours, and many non-specific symptoms. And so patients will often push for surgery because they will read on the internet that they have fatigue, forgetfulness, depression, muscle aches and pains. And we really counsel these patients that many patients do improve in these with symptoms like that, but some don't. And so just have to be realistic with their expectations in terms of curing their hyperparathyroidism. We performed we did not see localization on her ultrasound and sestamibi scan, nor did we see any definitive disease on her 4D CT scan. So we elected to do PET choline imaging for her, and this is an area of high uptake, and so usually it's described as having twice the uptake of what is present within the thyroid. And so she has an uptake of about 4.4 at the superior aspect of her thyroid, and then we can see it very well just just superior to her thyroid gland, and we found a 600 milligram parathyroid adenoma at this location. So just to review from a surgical atlas, that typical that for missed parathyroid glands are most commonly found in their typical location. So that is always the first place that we are suspicious of. But intrathyroidal locations are common, are uncommon, but what is more likely is to be flattened against the thyroid. So they have almost a pancake appearance that were missed at the initial surgery. Paraesophageal, especially for the superior glands, really have to reach far back within the TE groove and even in the prevertebral fascia of the cervical spine. They can be present posterior to the superior thyroid pole, as well as an undescended thymus. And then missed inferior glands, also within the typical location. They can be intrathyroidal. And then down in the chest, within the thyrothymic tract, we will, due to referral patterns, we actually see quite a few of these. And we pull up the thymus cervically, and we'll find a parathyroid adenoma present there. So within the thyrothymic tract or the thymus itself. So in summary, persistent disease and considering reoperation in these patients does require very thorough review and preparation before surgery. You really want to confirm your diagnosis, because the last thing you want to do is be in a reoperative situation and question if the patient has hyperparathyroidism in the back of your mind. You want to review previous operative notes and pathology reports in these patients. And then ideally, you have multiple concordant localization studies that will help guide you to your exploration. And working with an experienced endocrinologist to help you with confirming diagnosis and indications for surgery has been really key to um, being successful in these endeavors. Thank you.
Thank you, Benzon. It was a fantastic presentation and very, very good cases. So let me ask you something, and there are questions coming into my chat. But one of the issues I encounter in patients treated after parathyroid surgery is not only the hypercalcemia. In fact, I don't find that a significant problem. It tends to be more with a persistent elevation of PTH that drags on months after the parathyroid surgery. Can you comment on that? Is this just a variation of undetected hypercalcemia, or it has to be more about, the normalization of calcium homeostasis in the body? And how often do you see something like that too?
Yeah, so that's a great question. And that's the most common question we'll get with patients who 6 months after they go back home, as many of our patients travel from far away, they'll visit with their local endocrinologist who'll check a calcium and a PTH, and their calcium will come down nicely, and then their PTH will have elevation. It's difficult to assess normal calcemic hyperpara in these patients, so I think we should exclude that just for now. But up to 40% of patients will have elevation in their PTH. And we think that can be caused by multiple factors. So if the patient, for example, has concurrent renal disease and calcium leak, they will often present with persistent PTH. People who have had severe osteoporosis and are constantly remodeling bone. And what we think is we're unmasking secondary hyperpara in these patients. They may have malabsorption issues. Some patients have had a gastric bypass, for example, and they will have persistence of disease. As time goes on, many of these patients will normalize their parathyroid level, but we don't always know who or why they have an elevation in PTH. Our chair of endocrinology here, who is a bone expert, will often recommend not to check the PTH at 6 months, and just since we've defined cure as normalization of calcium, is just to check the calcium. And if that's normalized, that's reassuring that they've undergone successful surgery, because it does create a high level of anxiety for patients after surgery when they have an elevated PTH.
Thanks. There is a question about the direct comparisons of imaging studies, in particular PET choline versus 4D CT, and perhaps I would like to add even the consideration of MRI neck. What are your take on that? Do we have any studies comparing head to head?
So we don't, only because PET, and we are continuing to study this. It is difficult to do direct comparisons because you would have to have the same patient undergo. So, for example, the best study would be to look at the same patient and get a sestamibi, get a 4D CT, and a PET choline. That would be an extremely expensive study. And would expose the patient to unnecessary radiation. And so you tend to end up selectively picking these patients who have failed previous imaging studies, and then doing, and then they proceed to the next step. So there is no direct comparison between 4DCT and PET choline, but our at least anecdotal experience right now is that we've had very successful localization of patients who have not localized on 4DCT and then have localized on PET choline. We have not done the reverse with patients who have not localized on PET choline and then find something on 4-DCT, because they
Hmm.
usually will go through the accepted algorithm, and some of this is dictated by what insurance will pay for. So they'll pay for sestamibi without question, they pay for 4-DCTs without question, but then PET choline will be something that takes time and a lot of letter writing to get approved. So
No, that makes sense. Um, what about predictors of persistent hypercalcemia before surgery? Should we get more concerned with patients with very high PTH or very high levels of hypercalcemia? Those the ones that you think are going to be more likely to have some degree of persistent calcemia because of multi-adenoma or just difficult to remove adenomas?
So we actually see it a little bit of the opposite. So it's patients that have mild levels of hyperpara, which can sometimes be emblematic of multiglandular disease. So patients who have a calcium of 10.2, 10.3, for example, and no uptake of sestamibi on our subtraction imaging. And what we found is that that is a predictor of multiglandular disease. And so those patients, if you don't take enough parathyroid tissue out, um, then you can have persistence. So because you don't have a distinct target, and so sestamibi can be very helpful because that is a sign of hyperactivity. And so there's a reason that it's uptaking the sestamibi more avidly than the other parathyroid glands, and related to its hyperactivity. But in multiglandular disease, you're relying more on the size of the parathyroid in a four-gland exploration and visualization. You can complement this with doing parathyroid biopsies at the time to look for hypercellularity, but it really comes down more to search and judgment and comparison of the parathyroids to each other. And so if you err on the side of leaving too much tissue, they can be more likely to have more avid or a higher rate of persistent disease. Double adenomas certainly can be a risk factor, and we try to avoid missing these patients by using intraoperative parathyroid hormone. But I don't know of any studies that necessarily correlate the presence of a double adenoma with a higher degree of hypercalcemia.
Perfect. You already touched on this briefly, but there is a question about the role of fine needle aspiration in diagnosis and localization of parathyroid adenoma. How often do you do it, and if so, what are the potential harms of doing it?
Yeah, so that's a great question. We do utilize it, especially in patients who have borderline studies. The downside to it is it has to be visible on ultrasound imaging for us to do an FNA biopsy. We don't do CT guided parathyroid biopsies because the slices just aren't fine enough at times to do an FNA of the parathyroid. So it has to be present on ultrasound guidance. There is thought that disrupting the capsule of the parathyroid can lead to parathyromatoses, even in FNA. I think that is, I don't have any data that has really looked at that, but certainly is a real, it makes sense, at least um, from a physiology standpoint. And the other is when you do an FNA, you can cause bleeding, a small hematoma around it, and then a little bit um, of inflammatory reaction, which may make parathyroidectomy a little bit more difficult and increase your surgical morbidity in these patients. It's a little bit different than ethanol ablation, and really ethanol ablation in my mind is a last resort to treating hyperparathyroidism. And it's really in patients that have one gland left and are high risk for hypoparathyroidism. So, for example, a patient who's had a 3.5 gland resection in MEN1, we have looked at this, and reoperation in those patients has very high morbidity due to hypoparathyroidism. And so ethanol ablation has been our approach of choice in those patients. Their parathyroids are different because they are not necessarily adenomas, and the remnant that you left is not necessarily an adenoma. So ethanol ablation has been more successful in that particular patient population rather than someone with a remnant adenoma that's been left behind.
Thank you, Benzon. There is one question I think is quite pertinent to what is happening right now in practice, is that as we see these very just slightly elevated calcium levels with mild hyperparas, but patients very symptomatic. And we know that they have these non-specific symptoms. What do you suggest approach for these patients? How much benefit do you get from surgery, understanding that you can go in this downstream effects of perhaps needing a second surgery for a disease that might not be actual cause of the symptoms, and it could be certainly other problems like a fibromyalgia and things that depression, anxiety that can clearly cause the symptomatology. So what is your take about that?
Yeah, so that's a great question, and we see that very frequently these days. One is it's very important to have a discussion with the patient, and preoperative counseling is really the most important aspect of this. So you need to keep the patient's expectations real, in that what I tell them is that many patients with hyperpara have symptoms like these, and many will improve after surgery, but there are many that also don't have improvement. And so if patients have to realize that it's hard for us to know who is going to improve. One approach you could try is to place them on a trial of Sensipar or Sincalcet and see if they have improvement of their symptoms. And if they do, with normalization of calcium with Sensipar, that can be a predictor of success of improvement in their symptoms. But patients can be very aggressive in terms um, of pursuing surgery for this, and we do see that many patients have improvements in it. In SF36 quality of life studies, up to 90+% of patients do have improvement in quality of life with correction of their hypercalcemia. So it is a real it is real that that many will have improvement, but I think preoperative counseling is really key to keeping expectations real.
Absolutely. One concern after surgery with persistent hypercalcemia might be that the patient might have parathyroid cancer. Um, how often do you see that? And if so, there is any kind of imaging studies or something that might say this patient more likely to have parathyroid carcinoma?
Yeah, so parathyroid carcinoma, extraordinarily rare. Patients who have carcinoma will usually present with either a very high PTH level, but more likely a very high calcium level. So patients that are in the 10.5, 11, even close to 12, that is very unlikely to be parathyroid carcinoma. Patients with carcinoma usually can have calciums 13, 14, 15, even up to 20 I've seen. But just having a high but still the majority of those patients will not be parathyroid carcinoma. They'll tend to have very large parathyroid glands present, and then intraoperatively they tend to have a whitish appearance and not have many visible planes once you encounter them intraoperatively. I would recommend some sort of metabolic study to look at this. So PET choline is one option. and then 4D CT scan, and then using whole body sestamibi can be another option um, to look at uptake. But these patients are usually intraoperatively will be diagnosed, and the parathyroids tend to have a whitish appearance with more aggressive features than a normal parathyroid.
Thanks. There is a question about radiofrequency ablation. You mentioned ethanol ablation as a way to treat localized disease. Do you have any thoughts about radiofrequency or any experience at Mayo for that?
So we personally at Mayo have not used RFA. The we have used it in thyroid nodules, for example, and we have ongoing studies looking at it for small cancers. The parathyroids, unfortunately, especially the superior parathyroid, doesn't have a lot of tissue around it that can absorb the heat from radiofrequency ablation. And so it's not the same, for example, as thyroid nodules. In the inferior location, potentially you could use it, but really any remnant parathyroid tissue that's left behind will have the potential for recurrence. And I've reoperated on some patients who have had RFA for their thyroid, and it is a little bit more difficult. So especially in first-time surgeries, I currently don't see any benefit to using RFA right now, but as the technology improves, certainly can be something that could be a treatment for it in the future.
No, yes, thank you. A very good question here is you did mention ethanol ablation following autotransplantation. Can you talk more about the indications for that, for the ethanol?
Sure. So in a patient with who does not have any residual parathyroid left in their neck, for example, and only has one parathyroid left, or the auto transplant is their only parathyroid tissue left, you have two options in this patient. Well, you have multiple options. One is you could do nothing and and the patient will be hyperparathyroid for the rest of their life, and you would manage the complications associated with that to avoid hypopara. But in patients that need to have this removed, so for example, patients with renal failure or patients that are needing to be bridged to transplant, for example, um, you want to treat this, but you don't want to make them hypopara. So you could remove the transplant, for example, or debulk it, and then auto transplant again. But ethanol ablation helps, is just another adjunct that we have to our armamentarium to tackle this. So what we would do would be to inject a small amount of ethanol, and by small, it's really small, it's about 0.1 milliliters. And then that will destroy some parathyroid tissue, but and then you recheck their PTH and you see if it comes down to the level that you want it to. But what we have found is for adenomatous tissues, does not provide a long-lasting result. It's something that has to be done almost annually because patients will regrow their parathyroid tissue. But it's really in cases that you want to avoid hypoparathyroidism, that you know surgery will result in loss of parathyroid function.
Thanks, Dr. D. You mentioned the role of cinecalcet before surgery, sometimes to see if patients respond symptomatically. What about cinecalcet as a way to treat persistent hyperpara after surgery to avoid subsequent surgeries? Is that a possibility?
Sure, that certainly is a possibility. Syncalcet is effective in lowering your calcium level, but it is not necessarily effective in addressing all the side effects of hyperparathyroidism. So some patients will have normalization of calcium and their PTH will be lowered, but that's not the case for all patients. and they may still have persistence of osteoporosis and continued bone loss, for example. And so, or they won't have resolution of their symptoms and will still want to pursue surgery. Sincalcet can also have side effects. It has a lot of GI side effects for patients, and some patients will be intolerant to it. And there is a generic either coming out or already available, but it's still relatively expensive and unaffordable for some patients. And so it can be even with Medicare Part D for some patients. I had one patient who says she was still paying $1,100 for it every month. So I think
Wow.
it can really vary based
Yes.
on the patient. Um, and so I think surgery is still a great option, but medical management of persistent disease is also not unreasonable, especially
And
if we don't localize well.
yes, and one last question. You mentioned that pet calling might be the standard of practice in the future, depending of coverage and things like that. But centers that don't have access to pet calling, um, what is the recommendation in regards to CT versus other imaging studies? You mentioned some of that, but if you have to choose perhaps the best after pet calling, what would be your recommendation?
So I think it really depends on your center and your what your radiologist is comfortable with and what you're comfortable with reading as an endocrinologist and as a surgeon. So at Mayo, our sensitivity for sestamibi and I-123 subtraction imaging is about 90%, which is really excellent because the published data for this is somewhere between 78 and 80%, and in some centers as low as 50%. So if your center is low, um, has low sensitivity for it, then I would recommend 4D CT should be your imaging of choice. And we do have protocols available for that. Many surgeons are much more comfortable reading CT scans, for example, because the cross-sectional imaging provides you a really great map for finding these parathyroids. But it's really going to be center dependent. I would say 4D CT as a general rule, will be better than sestamibi and is the next best imaging study compared to PET choline.
Perfect. And Dr. D, thank you very much. This was a wonderful presentation. Very good questions. I think we want really to extend our grateful and hopefully we will have you again in this journal club. I would like to invite everybody for the next week. We're going to have a fascinating topic in anaplastic thyroid cancer, which is quite timely because of the recent release of anaplastic guideline by the American Thyroid Association. So thank you very much, everybody. And again, thank you, Dr. D.
All right, thank you.